live, but I'm very happy to join this session. I am in another meeting in Cleveland Clinic here in Columbus, but thank you for the invitation. So if it's okay with you, I go ahead and start the presentation.
Yes, please. You can hear you clear and loud, and let's go.
Okay, wonderful. So first of all, I'm very excited to give the presentation about the Protected Tower study that we completed and we presented at the TCT, a large randomized trial that we completed. And the idea about the trial came from the first trial that we did, the Sentinel trial of 363 patients, where it captured debris in 99% of the patients. Device was safe in this particular trial. There was no increased rate of MACE. However, we did not see the reduction in the new cerebral lesion volume. As you can see here, statistically not different, although the numbers were reduced. However, we did find that the stroke rate reduced from 8.2 to 3%, and therefore we decided to do a trial where we wanted to study the clinical stroke in transfemoral TAVR if it is reduced by the CEP, the cerebral embolic protection devices, across all risk groups and all commercially available devices. So this was a prospective, post-market, multi-center randomized trial in 51 countries. 3,000 patients randomized 1-to-1, TAVR only or TAVR with CEP. So 1-to-1, 1,500 patients. All patients had neurological exam at baseline and at 72 hours or discharge, whatever came first. And they were performed by the neurologic professionals with a modified Rankin score, NIHS score, MOCA, and CAM. Neurological exam in all patients was done post-procedure, and primary endpoint was all-cause stroke at 72 hours of discharge. We wanted to see that our assumptions were that the control would have 4% stroke, Sentinel would have 50% reduction, and that's how we powered the study. And we had an interim analysis, and the interim analysis with the DSMB suggested that we go to 3,000 patients. The primary endpoint of the trial was stroke through 72 hours after TAVR or hospital discharge, and the stroke types were ischemic, hemorrhagic, not otherwise specified, or covert. Most of the patients had ischemic stroke, and it was CEC adjudicated. Safety was studied with acute kidney injury as well as vascular side complications. So if you look at these 1,500 patients in each group, only 5.5%, so 94.5% of the patients could have the Sentinel device placed. So this is very important to keep in mind. The Sentinel device was able to be deployed in all these patients. If you look at the patient population, the control versus CEP, there are 1,500 patients in each group. Age was 80 years. Female gender was a little bit more in the control group compared to the CEP group, and the CHEDVAS score was 4.2. Patients were intermediate, extreme, or low risk in 1/3 each. If you look at the control versus CEP, the general anesthesia was used in about 26% of the patients, local in 75%, and most of the patients had tricuspid aortic valve. Balloon expandable valves were used in 60%, non-balloon expandable valve in 36%. If you look at the primary endpoint, and this is the most important message, that the primary endpoint was all stroke, was no different, 2.3 versus 2.9. However, the difference was 0.6%, statistically not significant. But if you look at the major or disabling strokes were 8 in the Sentinel group and 20 in the control group. So this difference was statistically significant. As you see here, it was 0.5 versus 1.3, difference of 0.8, and p-value of 0.02. So there was a 60% reduction in the disabling strokes. If you dig deep a little bit to say that what are these disabling strokes, it is very clear that if you look at the non-complicated TAVR-related ischemic stroke, 16 versus 3, very, very different. Because some of the other patients had CPR, and as I'll show you here, so there were 2 patients who have a hemorrhagic stroke, valve-in-valve, hemodynamic instability, required Impella. This particular patient had a cerebellar hemorrhage. And then there was a patient complicated TAVR with valve embolization required CPR. So unfortunate that these were all patients in the CEP group, but these kind of things would not be prevented by the filter device. If you look at the safety of the device was outstanding in terms of there is only one major vascular complication, a site-related vascular complication, just hematoma in one patient. And if you look at the discharge mortality at 72 hours of discharge, 2.9 versus 4.7, sentinel versus control, these are the stroke patients. If you look at the patients who had a discharge at home, again, the same thing we find that discharges home 70% in the sentinel versus 41% in the control, and higher intensity care needed only 30% versus 64%. So in whatever way you look, the disabling or major strokes were prevented by the CEP. Interestingly enough, if you look at all the subgroups, the results were very consistent. That in all subgroups, you saw that the point estimates were on the CEP side. Interestingly enough, if you just looked at the US population treated, even the primary endpoint was positive. So in the US population, the primary and the secondary endpoints both were positive. Of course, this was not pre-specified, so we could not stress it. But again, 1,800 patients in US, the primary and the secondary endpoints were positive. So what you could conclude is that the use of sentinel was feasible in 94.5% of the patient. It did not reduce overall procedural stroke, but the disabling strokes were reduced, especially the ischemic strokes, and no specific subgroups were identified that you could use the CEP for stroke prevention only in one subgroup. So you have to use it in all patients. This was published in New England Journal. I just want to show you two different minor things, just to conclude, that if you say that the TVT registry data, we see the same thing, that the in-hospital deaths were reduced with the CEP 1.4 versus 2.2. This is the NRD registry of patients with stroke. In-hospital mortality was reduced from 11.8 to 6.3. And if you look at Cleveland Clinic data, so now these are Cleveland Clinic patients, we started using systematically the patients. And if you look at it, now we have this large number of patients. So if you look at 1,800 patients who underwent TAVR with CEP versus people who did not have CEP and had, because it was not available at that time, very interestingly, we found that the overall stroke rate was not statistically different, is 1.45 to 0.4. But if you look at this, the NIH-SS score, stroke scale was reduced, major strokes were reduced, and modified Rankin score was also better in the patients who had stroke with CEP protection. Very importantly, 4 deaths out of 15 without TAVR with CEP, without CEP, 25% mortality. And if you look at the patients with stroke with TAVR and CEP, no deaths. So this tells us with all of these things that it prevents disabling stroke. It should be considered in all patients undergoing TAVR for reducing disabling strokes. And the safety of the device was demonstrated in the trial. The cost consideration may be important, but otherwise there's no other reason not to use this device for major stroke prevention. Thank you for your attention.